Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr Travis Brown. This is the story of troponin. Dr Travis Brown, I thought when you feel chest pains, you get rushed to hospital. I thought, well, they just do whatever they have to do. This episode shows so many more layers.
This is really digging down. And this is a conversation that actually happens a lot in chemical pathology, but not elsewhere. So we're actually digging really deep, and it's a controversial topic, and it's a hard topic. And we're talking about heart attacks. We're talking about troponin. Now, cardiovascular disease is the leading cause of death worldwide. And it's always been with us.
Sorry, doesn't that surprise you? Shouldn't other things have taken over by now?
Well, it is incredible. You think about that, but no, our heart is it will sound weird, but our heart is actually a very simple organ. It's a pump. And it's a pump that just keeps on pumping, and you need to supply it with oxygen and nutrients. There seems to be a limit of everything that we have, and it's been with us for all time. We always have had heart disease. We're getting better at managing it now. But the amazing thing is when you go back into, even though it will have been probably the leading cause of death for a lot of the time, infectious disease as well in previous times. But as we started to get better with our health, it's a leading cause of death. Our first medical accounts, things that we would recognize as heart disease or something alluding to a heart attack, is from 1768, William Heberdine. And he wrote about the chest pain radiating down left arm. He actually called it angina pectoris. And it was in 1879 that we found nitroglycerine was found by William Murrell, who found that if these patients actually had some pain, that this would dilate some of the vessels. But the amazing thing about all of this is it's not until the 1950s that we started to actually realize some of the treatments we could do for heart attacks. And this was first, aspirin reduced the risk of heart attacks. It wasn't until the 70s and 80s that we realized aspirin can actually reduce the mortality of patients experiencing a heart attack. So you're actually talking about the last half century, us managing it. And then if you start to look at recent articles in the last 50 years, there's just been an exponential growth in knowledge, in our understanding of prevention, of detection, management, treatment. It's overwhelming, and that's why I'm amazed at cardiologists, because they have to take all this stuff on board, the previous and new. It's just an incredible wealth of information that's coming their way, and so we think it's relatively straightforward. As you said, I've got a chest pain going, but they can be really difficult and challenging to diagnose sometimes when it's not straightforward. And look, it wasn't until the 1990s when we start looking at our diagnostic procedures. Then we talk about what's commonly referred to ACS, so acute coronary syndrome. And this is people we think as having coronary events, heart attacks. But in the 1990s, this was diagnosed through clinical presentation and changes on ECG. And a distant third test was a blood test. Now, this was creatinine kinase. It just
seems like a blunt tool.
Well, unfortunately it was. It's because CK is not specific to heart. And so muscle can raise it up. And there's a whole bunch of isoenzymes that we don't use anymore to separate it out from muscle and cardiac. But it wasn't a great test. It could provide indications, but it wasn't really useful. If it was elevated, there could be a few other things for it elevated. And the problem that presented is, well, how do you sort out patients who are genuinely presenting with a heart attack? And it wasn't until 1999 that the first generation of troponin came out. Now, this is a contractile enzyme, part of the heart, specific to heart, that is a protein that we can measure. And if you have damage to that, then it actually changes quite a lot your management of that patient. It's a reliable marker of injury. And so what people would do is then they would say, well, if you're having a heart attack, you're going to have that released into the bloodstream, and we will actually test it initially when you present and then 6 hours later. And if it's gone up, there is some form of heart injury happening at this point. And so that really helped us start to sort things out. It's now gone so well that people will actually look at troponin sometimes even more than the clinical scenario and look at it and say you're actually having a heart event, you may not know it.
Yes.
And so this is it's probably a challenge for us in these instances where doctors will know about troponin, but they might not know the subtleties. And that's what this podcast is about. And sometimes in a small subset of patients, there can be elevations that are either artifactual or due to other causes. And that's why I wanted to raise this. There are things such as troponin I and troponin T, which we will be discussing, as to what are we targeting with the assay. And this will have pros and cons.
You can't just keep it simple, can you?
Unfortunately, we can't. And this is where we start to look at the impact, particularly in pathology, is sometimes what happens when we do get a false positive, a troponin rise where it's not real or something is interfered with this. And we have an example of feedback that we received from a patient's family about when this happened. And it can be challenging for everyone involved.
On the 16th of June, my father was in the garden and came inside slumped in the chair looking sweaty. He was shivering, looked pale and had difficulty breathing. He got his colour back after sitting and his breathing returned to normal after some time. With an existing doctor's appointment for the following day, he just rested. He did not have any chest pain or other pain. The next day, I took Dad to the doctor's appointment and explained what happened. The doctor gave us a request form for bloods to be taken, including troponin. Unfortunately, taking blood is always a nightmare, and it's often difficult for people taking blood to find a vein. The following day, my dad had the blood test. That afternoon, the doctor rang me to say the troponin level was high. They recommended an ambulance be called, as he may be having a heart attack. The ambulance arrived and did an ECG. They spent 30 minutes on both arms attempting to cannulate, but were unsuccessful. Resuscitation pads in place, and the paramedics asked my father what his wishes were if he was to deteriorate when being transported to the hospital. My father, never liking a fuss, said, "Let me go." My mother, myself and my sister were there and all looked at each other in disbelief. I asked Dad the question again, as not sure if he understood the question. This time the response was, "Do what you can to save me." We all felt sick in the pits of our stomachs as he left in the ambulance. My dad arrived at the hospital and a full cardiac assessment was done. When we arrived, he was resting in a bed with an ECG machine. After an extended wait in hospital, we were still unsure of what was going to happen. Eventually, we were told he would be admitted for overnight observation. 20 minutes after leaving the hospital, I received a phone call from the doctor saying that my father had been discharged from hospital. They told me that the original troponin level was wrong. We turned around, picked up my father, who was grateful to come home, but were upset having wasted the paramedics and the hospital's time. Dr Christina Trambas is a chemical pathologist, medical director at St Vincent's Pathology and head of the biochemistry department. She's a fellow of the Royal College of Pathologists and Australasian Association of Clinical Biochemists. Christina studied medicine at the University of Melbourne after a PhD in immunology from the University of Tasmania and a postdoctoral fellowship at Oxford University, investigating the cell biology of natural killer cells. She is the chair of the RCPA Troponin Working Party, and Christina is our guest on This Medical Life podcast. Welcome, Christina.
Thank you very much for the invitation to talk about one of my favourite topics.
I can't wait. Let's dive in. So how did troponin testing change the management of chest pain and heart attacks?
Well, troponin testing gave us a biomarker of myocardial injury that was more specific and more sensitive than any other biomarker that had come before. And this ultimately gave us the capacity to diagnose and treat heart attack earlier. Troponin's been in use for about 30 years, and it quickly became the preferred biomarker, eventually becoming incorporated into the universal consensus definition of AMI, heart attack, and a cornerstone of risk stratification for patients presenting with chest pain. With successive improvements in troponin assay performance, we're able to both diagnose and safely rule out heart attack earlier.
There are different types of troponin assay. Can you tell us about those?
There are a few big categories of troponin assay. We classify them by, one, the analytical performance of the assay, particularly how low can we go in measuring troponin. Two, what we're measuring with, i.e. is it a main platform analyzer in the pathology lab versus a point of care analyzer that we use at the patient bedside. And three, what we're measuring, broadly speaking, are we measuring troponin I or troponin T? The most commonly used assays around the world are now the so-called high-sensitivity troponin I and troponin T assays measured on automated laboratory analyzers.
Now, is there a difference between troponin I and troponin T assays?
Oh, yes, there is. They're measuring very different things. So whilst troponin I and troponin T are both biomarkers of myocardial injury, they're independent proteins encoded by distinct genes with different functions and different patterns of release. So they both exist in a troponin complex comprising troponin T, I, and C. And this complex regulates the interaction between thin and thick filaments of the heart muscle in a calcium-dependent manner. And ultimately, the troponin complex controls contraction of the heart. When heart cells die, the troponin complex is released into circulation, but it's quite messy because it gets chopped up, leading to a range of different molecular forms of troponin that can be detected with specialised techniques. These include what we call a ternary TIC complex, a binary IC complex, and free troponin T and I, as well as truncated variants of all of those which have been clipped at the C and N-terminal ends. So these forms and their abundance change over time during and after an event. So some of the differences we see with troponin T and troponin I assays are, one, the molecular form that we're measuring. So the major troponin T species we detect in circulation is so-called free troponin T, whereas the major troponin I species exists bound to troponin C in this binary IC complex. But the concentrations that we measure are also different. So in AMI, the peak concentrations of troponin I are more than 10-fold higher than the peak troponin T concentrations, despite this one-to-one stoichiometry of troponin T and I in the ITC complex. And this likely relates to distinct patterns of release and proteolysis of troponin T and I. And during cardiomyocyte injury and death, much of the troponin from the cell is released into the circulation, but most of the troponin T appears to stay inside the heart, tightly bound to the sarcomere via tropomyosin and ultimately scavenged by resident cardiac macrophages.
Oh, right. So it's a lot of technical cells there. Steve's eyes are boggling out a little bit.
I'm sorry, Steve. I'm a chemical pathologist. I don't know if you were warned.
No. Look,
I've got immunology because I work with Travis.
And so look. So effectively the cells, then they're dying, they're releasing these chemicals and we're measuring them. We're measuring different components, so TNI and TNT. Can one sort of look at this and say, is one better or worse to measure?
One can, and the answer is that it depends. So they're both very good for ruling in and for ruling out acute coronary syndrome. And in general terms, they're roughly as good as each other. But there are certain groups of patients for whom one troponin assay may be more informative and of higher clinical value than the other. So one important group of patients are patients with underlying chronic skeletal muscle disease, including inflammatory, metabolic, and neurodegenerative disorders. So troponin T elevation is often noted in these patients, sometimes grossly so, even when there's no evidence of myocardial injury. And there seem to be a couple of reasons for this, but the most fascinating relates to the normal physiology of skeletal muscle regeneration in response to injury. So it turns out that during fetal development, there's some purposing of troponin isoforms, and cardiac troponin T is transiently expressed in skeletal myocytes and then it disappears. But when mature skeletal muscle is injured, this reversion or dedifferentiation to a fetal phenotype occurs, and the skeletal myocytes begin expressing, cardiac troponin T, and this is a real confounder. So if you're trying to exclude or rule in acute coronary syndrome in patients with underlying chronic skeletal muscle disease, troponin I can be a more useful biomarker of myocardial injury than troponin T. But there's another important group of patients where troponin T may be more clinically informative than troponin I, and that's patients with what we call antibody interference. So interference is a broad term we use to capture misleading results in a way when lab tests kind of lie to us. So endogenous antibodies are an important cause of interference, and in particular, some patients make autoantibodies to troponin that interfere with the troponin assays. And currently, we see this affecting troponin assays more often than troponin T assays, although it can affect troponin T as well, and sometimes it can affect both assays at once. So for some patients who end up with autoantibodies to troponin I, troponin T can be a useful test and more clinically informative in that setting. And I guess the other group of patients that's important to mention are patients with renal impairment. So troponin is renally cleared, and if you infuse purified troponin T and troponin I into lab models, they're both renally cleared. But in patients with renal impairment, troponin T tends to be higher than troponin I. Now, there's soon to be a new troponin T assay on the market which promises to solve this issue. It measures a particular form of troponin T called long troponin T that doesn't increase in renal failure. So we're watching that space carefully.
Now, we'll come back to interference a little bit in the next segment, but I want to come back to the one point of high sensitivity you mentioned. Now, is there a difference between high sensitivity when everyone's moving towards it? Is this a term that's useful?
Yes, it is a useful term, and it's basically a performance claim. So a high sensitivity troponin assay can measure really low concentrations of troponin very reliably. Technically, to be classed as a high sensitivity assay, a troponin assay needs to show imprecision of less than 10% CV at the 99th centile, which is the clinical cut point embedded in the universal consensus definition of AMI. And furthermore, the troponin assay needs to be able to measure detectable troponin in more than 50% of a healthy adult reference population. So it might depend on who you ask, because for those clinicians who have been around to see the successive generations of troponin assays, there was a lot of backlash with the high sensitivity assays, and in general as we became more sensitive, because we were picking up smaller and smaller events and much more sensitive in picking up myocardial injury. But I have to say that high sensitivity troponin assays are absolutely superior because of what you can do with them and also because of what they've taught us. So high sensitivity troponin assays measure troponin at concentrations that are at least an order of magnitude lower than previous versions of the assay. So as a consequence, they allow us to rule in and rule out AMI earlier and faster. In Australia, each year we've got about 1 million individuals presenting for the evaluation of suspected ACS to our EDs, and about 90% of these individuals won't be having an AMI, so it's really important to be able to rule them out accurately and safely, and ideally as fast as possible. So to be able to rapidly rule out AMI and safely discharge those patients who aren't having an event, that's a big win for emergency departments, and it can improve overcrowding and resource utilisation in the ED. But as I mentioned, high sensitivity troponin assays have also transformed our understanding of troponin and the pathophysiology of troponin release. Because of these assays, we now know things we didn't know before. We know that there are sex-specific differences in circulating troponin, with the 99th centile higher in men than women. We know that you can detect troponin in individuals with pristine cardiovascular health, including children. And so this is challenging the paradigm of troponin release, once believed to occur only upon cardiomyocyte death. we now believe that troponin release can occur with reversible cardiomyocyte injury, though it's been more difficult to definitively prove this.
Anyone who's worked in the emergency department will be familiar with someone coming in with chest pain doing serial troponins being 6-hourly interval. There's now getting to the point with this high sensitivity that the hours are reducing such that you can do 2 or 3 hours and actually see if there's a change. And emergency departments are becoming interested in this because it gets patients in or out earlier. Is this common? Is it able to be done? Is 2 to 3 hours between serial troponins now valid?
Yes, in fact, there's a very wide, solid evidence base for this. So it's because of these high sensitivity assays, as you say, that we're able to progressively introduce shorter intervals of serial testing, and it's evidence-based and it's safe. So the current Heart Foundation guidelines recommend an interval of 3 hours when you're using a high sensitivity assay. If you're using a previous contemporary, they're called contemporary assays, you need to have an extended window of serial testing. But for the high sense assays, you can use 3 hours. It's likely that the updated guidelines, which are in process at the moment, are going to recommend even shorter intervals, including a 2-hour protocol, which is already in use in some centres around the world. So, of course, we don't interpret troponin in isolation, but in the context of the wider clinical features, risk factors and ECG. So there are 1-hour protocols with a solid evidence base now, but to make such a rapid turnaround time at the moment, you probably need a high sensitivity point of care troponin assay available in the ED. And while there are several high sense point of care troponin assays now available on market, they're not yet in wide use as their costs and benefits are still being weighed up. But I should also say that there's now a solid evidence base for single sample rule out. That means being able to have on one test confidence to say, I don't think you've got an AMI, or you don't have evidence of an AMI, we think you're safe to go. Now, this it of course comes with a caveat. The exception is early presenters who present within 2 hours of symptom onset. But apart from this exception, early rule out protocols are deemed safe with a less than 1% risk of AMI and major adverse cardiovascular events in the short and longer term. But the big issue is that for us to safely run those early rule-out protocols, we need to be scrutinising troponin assay performance at that very low end. And so the industry more widely has to recalibrate ourselves so that we can reliably do that. And in particular, lot-to-lot variations in troponin assay performance, as is common for other assay performance, that's something we need to get a better handle of and also be able to monitor it much more carefully.
We're at about third and fourth generation assays. Are they getting better and better? Because one of the comments is that we're now detecting a whole bunch of stuff that may not be relevant.
Yes, so there's this idea that when troponin assays were analytically worse, meaning they weren't as sensitive, they were clinically much more useful. That was back in the day when if you detected troponin elevation, someone was having a big event. We're now on to technically the fifth generation of these assays with the high sensitivity assays. And as I alluded to, they measure an order of magnitude lower. So we now measure troponin in nanograms per litre units, not micrograms per litre, like the fourth generation assays. And this absolutely allows more sensitive detection of heart injury. But as you point out, is this better? Well, that depends. It is better because we are more sensitive at detecting myocardial injury, but of course not all myocardial injury is heart attack. So there are a long list of other causes of myocardial injury. AMI is only one of them. The most recent universal consensus definition of AMI defined myocardial injury in it as an elevation of troponin above the 99th centile. So there's increasing distinction between myocardial injury and AMI.
Can someone have an elevated troponin and nothing to do with cardiac injury?
Unfortunately, the answer is yes. So in some individuals, which we've already touched on, troponin elevation occurs in the absence of myocardial injury, and this is really clinically challenging for these patients. And by definition, these patients, because of that troponin elevation, their considered high risk. And so they undergo often unnecessary evaluation, including sometimes invasive procedures like coronary angiography. And so we all want to avoid this as much as possible. Causes of troponin elevation in the absence of myocardial injury include the skeletal muscle disease group that I've mentioned, and also the troponin interference group. And troponin interference turns out to be much more common than we've realised.
Going back to the old tests, is there any role for creatinine kinase anymore in heart attacks?
No role anymore.
Well, and also CKMB, because that's occasionally asked. So that's useless as well.
It's a bit of a relic. It really doesn't have a role in routine practice. Occasionally, if a lab has access to it, they might use it for a very specific lab interest purpose, but no role in routine practice anymore for ACS workup.
May that never be the way they talk about you, Dr. Travis Brown.
Now, when we're looking at troponin, when should and shouldn't troponin be ordered?
There are growing niches for troponin testing, but the major indication is still in the investigation and management of suspected ACS. We are seeing troponin incorporated into clinical protocols to monitor patients with amyloidosis, for example, in the workup and monitoring of patients prior to the commencement of clozapine therapy. And in future, it's likely that troponin will be incorporated into long-term cardiovascular risk assessment. So it's really important for clinicians to note when they request a troponin that it is a high-stakes test, and troponin elevation is going to classify an individual as high risk. So you shouldn't request a troponin without an appropriate indication, and you should always provide your contact details or hand over information so that the lab is able to follow up that result with you.
This actually touches on an area because this troponin is commonly an out-of-hours conversation, sometimes with pathologists talking to patients because they're saying you've got an elevated troponin. If a doctor's considering requesting a troponin, should they go straight to hospital?
It's an important question, and it does depend on why they're considering requesting it. So a patient with current symptoms suggestive of acute coronary syndrome, absolutely, they should be referred straight to hospital for evaluation and monitoring, and troponin testing shouldn't get in the way of that referral or delaying that referral. But sometimes a clinician might be seeking to rule out ACS as the cause of a previous event or previous symptoms. For example, a patient may present several days after a bout of chest pain. They're well, they're stable, and the doctor wants to usually exclude ACS as a cause of that chest pain. So it's appropriate to order troponin in that setting. Obviously, as I've said, you need to provide contact details, because sometimes when you think you're going to rule out disease, you might get a big surprise and find that the troponin's very elevated and you need to follow up that patient after hours. But as I said, troponin's increasingly used outside of the ACS setting, so in cardiac amyloidosis, which is staged and monitored based on troponin and other biomarkers. And we're seeing an emerging role for troponin incorporation into long-term risk of cardiovascular event prediction. So in the 2024 European Society of Cardiology guidelines for management of hypertension, troponin is suggested as a useful test to identify existing cardiovascular disease and what they term hypertension-mediated organ damage. So again, and I guess this is a really important lab point, as you've mentioned. It's vital that clinicians requesting troponin in the community provide their current after-hours contact details or appropriate handover or escalation pathways so the lab can safely escalate cases of troponin elevation, because from a lab perspective, we don't always know why a clinician has tested it, and we have to treat it as extremely high risk.
Well, what an exciting look into this particular field of medicine. Amazing. Let's just take a quick breather, let my heart rate come down to resting rate, and we'll resume in just a moment. We continue our discussion now with Dr Christina Trambas as we turn our attention towards some of the issues that have arisen with testing troponins and cardiac markers. Christina, are all troponin assays created equal?
I have to say our vendors would like us to think that some are more equal than others. But in truth, there's no perfect troponin assay, and each has its pitfalls and strengths, as we've touched on already.
Is there some difference between sensitivity and specificity, or what is the sensitivity and specificity of testing troponin?
It depends how you use them in terms of the cutoffs that you use and the interval of testing, etc. But when used in defined diagnostic algorithms and clinical decision pathways, troponin has very high sensitivity for detecting myocardial injury and diagnosing AMI at around 99% or higher. Its specificity is poorer, as you'd expect, knowing that myocardial injury doesn't equate always with AMI. And in particular, specificity tends to decline as people get older because troponin elevation increases with age, but we don't use age-specific 99th centiles. They're not currently recommended. Specificity can also be poorer in individuals with renal failure. And in general, with the different protocols, specificity is poorer with single sample protocols and higher with serial protocols.
Do you believe it's important for doctors to know which troponin assay they're running in the laboratory to manage their patients?
I think that T versus I distinction is important for all clinicians to be aware of because they are quite different, and particularly those clinicians looking after patient groups for whom T and I might be very different. I think it's also important for clinicians to know that even for troponin I, the different assays read differently, so the numbers will be different. They're not standardised. So each troponin I assay has its own assay-specific 99th centile, and you can't really compare one troponin I result directly with another. So if you're testing with one assay and then you want to compare with another assay, you can't really say this has gone up or down necessarily if they're different troponin I assays.
We did start the whole episode with an incident where a patient gets two different results. And how do we explain to doctors where one assay can be positive and another assay can be negative?
So if you've uncovered an interference with a troponin assay, that tends to be an easier thing to explain. So you take the doctor through that particular interference, whether it's troponin autoantibodies or skeletal muscle troponin, for example, and explain why that interference is causing discrepancy across the results. It can be a little harder to explain when it comes to comparing troponin I assays, because conceptually that seems a bit harder because you're no longer comparing apples and oranges like T and I, but comparing apples with apples. And we have to say, well, that's a different variety of apple here. But it's even harder to explain when you don't identify an interference. This comes down to troponin assays measuring different forms of troponin depending on where those antibodies that are used in the assays are directed to on the troponin molecule. So in renal failure and in the elderly, it's more common to see troponin T elevation than troponin I using current non-age-specific reference intervals that are in use. So sometimes those conversations can be a little bit difficult because we'd all rather believe that the numbers that we report on the page are very absolute. But we have to have those more nuanced conversations about lack of utter correspondence, absolute correspondence between the different assays.
Is there much discordance between troponin assays such as I and T?
Uncomfortably, there is much more discordance than we'd prefer. It is particularly for those T and I comparisons, and it's more marked in some patient groups. So when you compare directly in the same set of patients, you will see discordance. We've already touched on patients for whom that's more exaggerated, such as patients with renal failure, in the elderly, patients with skeletal muscle disease, patients with these autoantibody interferences.
Don't the notes that the pathologists send back clarify all these situations so the GP knows exactly what's happening?
Depends on which circumstance, but often the strange thing is pathologists and labs don't know why a troponin's being requested. And so the important part behind that is if we see an elevated troponin, we immediately think worst case scenario, patient's having a coronary event. So if we're contacting the patient, we're actually saying you're having a heart attack, you go to hospital, and they may not be happening. That's the problem. We actually don't have the information. And so this is why when we're looking at doctors don't actually know the difference between like what assay we're running. And so that's why we're sort of doing this episode, is to saying there's a TNI and TNT. And the problem, some laboratories are having discussions now about which is the most useful in a clinical scenario. And I don't know anyone's got the actual, TNI versus TNT. Well, we have TNI, we're looking to go to TNT, but I'm not sure if people are doing vice versa. And so that's why we're sort of raising it. But there is something I want to raise now, and it's something called macrotroponin. And what is macrotroponin and how does it affect results?
So macrotroponin is a complex form between the troponin autoantibodies that I mentioned and different troponin species, macro meaning large. So for reasons we don't understand, some patients, and more patients than we think, make these autoantibodies. And when you go looking for macrotroponin interference, it's much more common than we once believed, and some case series show prevalence estimates of 5 to 10% or even higher in individuals with troponin elevation. So macrotroponin generally causes elevation in troponin results because the autoantibodies bind to the troponin species and hold it in circulation, interfering with its normal clearance mechanisms. In theory, and there's evidence that this can happen, although we believe it's not as not very frequent, fortunately, but in theory, autoantibodies to troponin can also potentially cause falsely low results if those autoantibodies bind to the same epitopes that the capture or detection antibodies of the assay bind to.
So these will be patients who don't have myocardial injury but test positive for troponin.
That's right. It's really challenging for labs and clinicians to deal with these patients.
So when is it important to consider this patient could have a macrotroponin?
It's important to consider macrotroponin whenever a patient's troponin result doesn't fit with their clinical findings, or when you have a discrepancy between two troponin assays. So once upon a time, these patients would come to attention classically after the patient had gone to the cath lab, and the cardiologist would ring and say, this patient has pristine coronary arteries and they've got a troponin elevation of X. And then we go and do the further investigations. But as I said, now we're looking for them. We realise that these macrotroponins are out there at a much higher prevalence. So it's important for our clinicians to contact the lab if they're suspicious, and we can do those additional tests. But it's also important to note that at the moment we don't have a routine automated test to pick up these antibodies. So it's very difficult for labs to automatically screen for them. So we need the clinician to flag something suspicious to us, because otherwise we won't necessarily be able to go looking for it.
Well, that brings us to PEG testing, so polyethylene glycol. And what is that and what's it used for?
So polyethylene glycol is a chemical that we can use in the lab to test for macro interferences. So PEG basically forces macromolecular complexes like macrotroponin out of solution and they precipitate. So if you do PEG precipitation and a high troponin result disappears, that's very suggestive of macrotroponin interference. PEG's really useful because most labs have access to it, but it's a screening test only. It's not definitive proof of macrotroponin interference. Having said that, most samples that have this low PEG recovery or disappearing troponin on PEG precipitation, most of them will turn out to have macrotroponin interference. So in theory, other antibody interference can also be detected with PEG precipitation, but these other antibody interferences are much less common than macrotroponin interference as far as we can tell.
Now, are there any other important issues or interferences with troponin or troponin testing that clinicians should be aware of?
So in that category of other antibodies, there's a type of interference where certain individuals might make antibodies that react with the assay ingredients, if you like, the assay antibodies specifically. These include anti-animal antibodies like human anti-mouse antibodies, HAMA we call them. So over the years, manufacturers have been tweaking their assays by adding in proprietary blocking agents that minimise this problem, and we don't tend to see a lot of it now, but it's still possible, particularly in individuals who might work with animals, animal house workers, for example. But apart from these antibody interferences, troponin assays can also suffer from what we call flyers or non-reproducible results. Typically, a troponin flyer is an elevated result that on repeat is normalised or much lower. We don't fully understand why flyers occur, but sample integrity or sample quality is one important contributor. So a cruddy sample it has a higher risk of a flyer, and some analyzer hardware can contribute to flyers. So the actual design of the analyzer itself can contribute to flyers. So these are other sorts of troponin problems that we have to be aware of.
For doctors who have encountered such issues, so we're really probably talking about general practitioners who are patients who have come back, or emergency physicians, maybe even cardiologists, what's the best way to explain this issue to patients and families as to what's happened?
If we're trying to explain that autoantibody interference, that's a really important thing for the clinician and the patient to understand, because those autoantibodies tend to be persistent. And what that means is that if the patient has a problem with that autoantibody interference now, chances are they're going to have a problem with that autoantibody interference in the future. It's really important to acknowledge that individuals who have these autoantibodies can also have events. So we need to try to keep these patients safe, whether they're not having an event or whether they're having an event. And I think it's a big challenge for labs and clinicians across the different health services to look after these patients as we'd like to. But so it's important for the clinician to understand that for that particular troponin assay, if someone has macrotroponin interference, they're likely to have a problem with that assay into the future, months, years. However, if they turn out to be having an event, we will see a rise and or a fall. So in the universal consensus definition, the rise and or fall of troponin is really an important part, and that's a saving grace for how we can manage these patients. If they turn out to be having an event, they will show a rise and fall of troponin. It's just the troponin won't completely fall away like other patients without the antibody interference. So that's trying to keep these patients safe when they have the interference and they're having an event. But more often they have the interference and they're not having an event, and we just have to prevent them having unnecessary, especially invasive procedures. And again, having clinicians who are aware of this problem, patients themselves knowing about this problem so that they can let the clinical team know that they've had this problem in the past, and for clinicians to reach out to the lab and use us, because we can as quickly as we can try to resolve these issues for them.
There's one last question I have, and we mentioned it earlier about point-of-care devices, because that tends to be a little bit of a headache for chemical pathologists, because emergency and ICU departments love them. We don't like them relying on them too much, because the results can be a little bit sort of have a bit of more variation than the normal analyzer down the hallway. Is point-of-care troponin assays, are they reliable and as sensitive as the normal assays that we have?
A few years ago, we could clearly say, no, they're not. But in the last few years, with the introduction of high sensitivity point-of-care troponin assays, we have to say that actually the precision of these assays is on a par with, or very close to, mainframe automated lab troponin assays. That hasn't opened the floodgates, though, for a number of reasons. One is cost. Point-of-care troponin assays are much, much more expensive than the lab assays. And so that economic modelling is a really important consideration. Two, you have to have the right infrastructure in place for a point-of-care assay to be used in a way that really expedites management, safe management of these patients. So you need a proper network of staff trained in use of those assays and interpretation of those assays. And you also need a pathway for patients for whom admission is going to happen, when now you have the scenario where this point-of-care troponin assay that was done first is going to measure differently to this lab assay. Even if it's measuring troponin I, you're going to get different numbers. And you're going to need a way to help your clinicians understand what that means so that they can use that. So these assays, point of care assays, aren't used routinely around the world yet, but there are a number of big trials in process or already published showing that there is a role for them. They're quite controversial at the moment, as you point out, but one of the things we'll need to do if we're going to embrace those point of care pathways is to have a pathway so that if a patient is admitted, we can reanalyze that first sample on the mainframe analyzer to show here's your delta, here's your change, moving from apples to apples, not the point of care to the mainframe, because that's too difficult to interpret.
Okay.
I'm sorry, that was a messy answer, I believe.
No, it was very helpful because I'm going to delay my visit to ED for another few years then. Is there any final advice or any comments you have for doctors, general practitioners about troponin testing?
I think it's just reinforcing that the lab is there to assist you in interpreting troponin results, all results. And as you pointed out, Travis, the lab may not know why you've ordered a test. The lab won't know if this test is out of keeping with the clinical features unless you've told us. So if there's any discrepancy or something that doesn't make clinical sense, reach out to the lab and we'll help you resolve that. And at risk of neurotically harping on about this, but it's really imperative that we have after-hours contact details, that after-hours scenario where a lab has to escalate action for an elevated troponin result, the clinician requesting that test is the best place clinician to follow up that result. And if a lab has to follow up the result because we don't have after-hours clinical details, we'll do the best that we can, but we're not going to be able to give the same standard of care. We don't know why you've requested troponin in the first place. And we'll have to, in our due diligence, assume that this patient needs to be sent to an emergency department, even if you've requested it for monitoring cardiac amyloidosis, for example. So make sure that those after-hours contact details and escalation pathways are clear to the lab, because that's going to help your patients in the end.
Dr Christina Trambas, thank you so much for being part of This Medical Life.
Thank you so much for having me. Bye-bye.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/IN/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.